Ladies and gentlemen, we move on to the next presentation that features on the topic Radiologist Proposes, Cardiologist Disposes, CTA or CAG, which is the better choice. May I invite for the next 10 minutes Dr. Priya Jagia. She is the additional professor of cardiology at the All India Institute of Medical Sciences, New Delhi. I beg your pardon, cardiac radiology.
Good morning, respected chairpersons, ladies and gentlemen. So today I'll be talking about when to do a coronary CT angiogram and when to do a catheter angiogram in which patients. It's not CT angio or coronary artery, a catheter angiogram. It is which patient, it's a patient which determines which investigation you are going to do. So catheter angiography, there are many techniques which are available for evaluation of ischemic heart disease, but for the purposes of evaluation of the coronary arteries, catheter angiography and CT angiographies are the two techniques which are used by the virtue of their high spatial resolution. Catheter angiography is still the gold standard because of its high temporal and spatial resolution, and also because of the fact that it is not affected by the cardiac motion and by the respiratory movements. But it is an invasive procedure, has got a finite morbidity, and let's not forget that 1/3 of these investigations will turn out to be normal and only half of the patients will undergo an intervention. Also, you require a lot of contrast, multiple injections need to be done, and there is a radiation involved. The other important thing is the catheter angiogram allows you to see only the lumen. You can see only the opacified lumen, you do not see the wall. So, it's blind to the wall. The other investigation available is the coronary CT angiogram. The most positive point about coronary CT angiography is that it is a non-invasive procedure, involves a very short examination time of around 9 to 10 seconds, gives you a very good quality 3D images in a single breath hold and in a single contrast injections. So why not do a coronary CT angiography in each and every patient? There are some issues, the major being the radiation which was supposed to be very high with previous scanners, but with the advent of higher multi-slice CTs with 256 slices and above, now the radiation has come down to less than that involved in the catheter angiogram. In fact, there are studies which have talked about less than 1 millisievert CT dosage and reasonably good sensitivity and specificity. So let's talk about how CT fares in luminography vis-a-vis the gold standard invasive catheter angiogram. The sensitivity and specificity is very, very good, more than 95%. And the thing to note is the negative predictive value has always been in the range of 99 to 100%. That means you can rule out a coronary artery disease if the coronary CT angiogram says so. But there are some limitations of coronary CT angiography. If the heart rate is very rapid, more than 120, if it is irregular, if there is a lot of calcium score, like in this case, you can see there is a lot of calcium in the, okay, I'm not able to move my arrow. There is a lot of calcium in the right coronary artery, so you can't talk about the artery beneath the calcium. So a very high calcium score again precludes visualization of the artery underneath. Stents which are smaller than 2 mm are difficult to assess on CT. Also, if the patient is uncooperative, is not able to hold breath or is obese, then also you may get some artifacts which may preclude good visualization of the coronary arteries. So there are criteria, appropriate use criteria which have been laid down for the use of coronary CT angiography. Let's talk about symptomatic patients who do not have a known heart disease. So they are coming to you. The ECG turns out to be normal, the TROP T is negative. So these are the patients where you have a low to intermediate probability of having coronary artery disease. These are the patients who should be referred for a coronary CT angiography. In an acute presentation, if you definitely think there is MI, there are some ECG changes, there are TROP T is positive, then please do not send these patients for coronary CT angiogram, send them directly to the catheter for the catheter angiography. Yes, if you see again a low test or an intermediate test probability, it is appropriate to send these patients for a coronary CT angiogram. What about asymptomatic patients? Should we be doing a coronary CT for these patients just for the screening purposes? No. You can do contrast CT, non-contrast CT for coronary calcium scoring if the patient has a family history of premature heart disease and he is at intermediate risk because of the presence of multiple risk factors. Also, you may do in these asymptomatic patients if they are to go for a non-cardiac surgery or a non-coronary cardiac surgery if they are again at an intermediate risk because of presence of the risk factors. The other area, the other thing which you want to see in the coronary artery evaluation is the plaque imaging. Like I said before, the catheter angiogram will just show you the lumen, it does not show you the wall. So you can see the wall, you can have a look at the wall in the CT. You can see the plaque on the CT but not on a catheter angiogram. So this is where the coronary CT angiogram scores over the catheter angiogram. And we all know that 80% of the fatal MIs are caused by non-stenotic plaque, which form the major bulk of the atherosclerotic burden in the society. So we look for the vulnerable plaques. So a plaque which has got a positive remodeling, which has got spotty calcification, and one which has got a fatty core. So these are the vulnerable plaques and are likely to cause acute coronary syndrome. So if all these are present, there is more than 95% risk of patient ending up with a plaque rupture and acute coronary syndrome. And if all of these are absent, there is no soft tissue plaque, then you can say there is 0% risk of this patient going for a ACS. Regarding coronary artery calcification, which is used for screening purposes for risk stratification, there are many publications. So what they have found is that a 0 score can actually virtually rule out an obstructive coronary artery disease, and these patients can be sent home with negligible event rates during their follow-ups. And if it is present, if there is calcium is present in the coronary arteries, then it is 99% sensitive for ischemic cardiomyopathy in patients with heart failure who have come with unknown etiology. But let's not forget that even if there is a calcium score of 0, there may still be non-calcified plaques, but the obstructive plaques are distinctly uncommon with a 0 calcium score. The other area where coronary CT angio can be done is when you are suspecting a congenital anomaly of the coronary artery. You can see not only the origin of the artery, like in this case anomalous LAD which is arising from the RVOT, but you can see the course of the artery also. On the catheter angiogram you can see only the opacified artery, but you are not seeing the underlying structures. So here you are seeing the underlying structures, so you can see the entire course of the artery and also its termination. So it's appropriate to do coronary CT angiogram in patients when you are suspecting a congenital anomaly. Also, this is another scenario where coronary CT angiography can be asked for. You are doing a catheter angiogram and you see something like this, a stenosis at the left main, and you are not sure whether your catheter has caused this stenosis because of spasm or is it a left main disease. So a coronary CT angiogram will show either the stenosis or the normal left main artery as the case may be, and can resolve the dilemma. For the assessment of in-stent restenosis, 64 slice and above CT are good enough. It has a good diagnostic accuracy, more than 92%. However, if the stents are small, like I said, smaller than 2 centimeter or those with lot of metallic amount, then the sensitivity comes down. However, the negative predictive value is good. So keep that in mind. Whether you have put in a smaller stent, then go for a catheter angiogram. If you have a proximal larger stent, you can send for a coronary CT angiogram for a follow-up. For the assessment of patients who have had CABG, coronary CT angiography is the investigation of choice. It has got a very good sensitivity, specificity and negative and positive predictive value. It circumvents the need to selectively hook each and every graft and do repeated injections. A single contrast injection will show you all the grafts in their entirety. So for CABG, send your patient for coronary CT angiogram. You can add incremental value to your coronary CT by doing stress CT perfusion and viability images. There are some studies which have discussed how the sensitivity has increased after adding the CT perfusion. For example, in this case, there was a lot of calcification in the LAD circumflex artery, and on adenosine stress CT, there was a a perfusion defect in the lateral wall suggesting involvement of the circumflex artery. And the same was then seen on the catheter angiogram. The LED lesion was not significant. RC2 had a mild lesion and there was an occlusion of the circumflex artery. So you have an incremental value with the CT perfusion and also by doing the FFR, which is now possible with the CT also. So you can see the fractional flow reserve, which also has been talked about in many studies, and I'm sure Dr. Bera will also be alluding to them. So you can do this FFR by adding no contrast, radiation, cost or medication. It's on my last slide. So I would like to end by saying catheter angiography still remains the mainstay of the diagnosis and the planning because of its very high spatial and temporal resolution. Though the CT are becoming more and more advanced with higher temporal and CT resolution, but still at the moment the catheter angiography is unmatched for its temporal and spatial resolution. Also, it is not affected by the motion artifacts because of cardiac motion and breathing, and it has the ability to look beneath the calcium, stent and the clips. So it is still the gold standard, but at the moment it is advisable to do a CT coronary angiography if you are suspecting a patient who has a patient to have congenital anomalies of a region and course, if the patient has had a CABG and has come for a follow-up, if the patient has got an atypical chest pain and you think there is a low probability of having coronary artery disease, for a preoperative patient, and also if there is a chest pain in low risk category. You may consider doing CT coronary angiography in patients who have low intermediate risk and have stable angina, but do not refer patient for CT coronary angiography just because they have want to be screened. So don't do for asymptomatic patients for screening of the disease when there is acute coronary syndrome and if the patient is symptomatic and in a high risk category. So these are the patients who need to be sent directly for the catheter angiogram. Thank you.
Thank you for giving a very, very excellent review of CT angio, removing some of our doubts. The problem occurs, although you have clarified it, we get patients of diabetes, hypertension, who have got a premature family history of CAD or something, many other factors, and they want us to exclude coronary artery disease.
So
now what we do a stress echocardiogram. Now stress echo has got its own limitations.
So the subset which you mentioned, diabetes, there are risk factors, there is a family history. You can send the patient for a coronary calcium score.
Coming to the same place, they wanted to know whether we have got a coronary artery disease or not. So rather than sending for CT angio, we can only send for coronary calcium.
Absolutely.
No need for that.
Yes,
a big
yes.
doubt has been cleared. But somehow that like a fool we have been sending patients for a CT angio because we could not. Though as you said 120 heart rate. Previously they used to say 70 or 80.
No sir, we are using dual source CT and ever since 2006 we are not giving beta blockers at all.
Not at
Even
all.
up to 120 if the heart rate is regular, the
Yeah.
keyword is regular,
That
then we are not using anything. For irregular heart rate, then obviously it becomes a problem. You may have to do some, editing
Any
of the
particular
ECG.
weight of the patient before beyond
No,
which we
sir,
cannot send for
with
CT
the newer
angio.
CTs, it is possible to increase the MAS and KVP, but then yes, if it is more than 120 kg or so, you are more likely to have artifacts and the
As a
visualization will not
layman,
be.
coronary calcium is a very strong test to exclude a coronary artery disease.
Yes, sir. Yes, sir.
Okay, thank you
Yes,
so much. Mike?
There are three important clinical conditions which come across in day-to-day practice where catheter angiography fails to give the diagnosis of this subset of patients. Number one, subclinical CAD with microvascular dysfunction. Number two, small vessel artery disease. Number three, myocardial bridges. How do you utilize your modalities in all these three important conditions where catheter angiography fails to diagnose?
So I'll talk about the third condition first, the myocardial bridging. We are able to see the myocardial bridging very nicely on CT angiography. However, yes, we can see on the systole that there is a compression and we can comment. Rather, we are picking myocardial bridging more often than not using the coronary CT angiography versus a catheter angiogram. We are able to comment. Rather, talking about microvascular obstruction, yes, we can do that if we are doing a perfusion study along with this. If we are doing just a coronary CT, probably we will not be able to. If it has to be a retrospective study, we should be able to see the amount of enhancement. And if we are doing a perfusion study, we will be able to pick up the microvascular obstruction also.
Okay. Thank you, Dr. Priya.